Okay, I want to talk about this interesting case of a distal radius fracture. This was a 43-year-old male presenting with right wrist pain. He states he came to the emergency department. He states he fell off a 5-foot ladder with immediate onset of pain and inability to push off. He denies any medical or surgical history. He doesn't smoke. On exam, he has significant swelling, tenderness, and decreased range of motion. His skin is intact, so there's no open injuries, and he has no obvious neurodeficits. These are his initial radiographs in the emergency department. On the left, you can see the initial set of radiographs. And what you see here is a PA film of the wrist. You see the distal radius right here, and the ulna, okay, and the carpal bones. And the obvious fracture of the distal radius here, okay? So you see a nice fracture fragment through the articular surface. You see comminution. There's multiple fragments here. Very ugly looking fracture pattern. There's also an ulnar styloid fracture here. On the lateral view, same films, lateral view, you see the radial fracture here as well. You see a volar component. You see some fracture fragments dorsally, and this is a very unstable, ugly looking distal radius fracture. In the emergency department, he was reduced. He didn't require a ton of reduction and placed in a sugar tong splint. And you can tell he's in a splint now because he's got this nice cast material sort of silhouetting the two films taken afterwards. And you can see that there's a little bit of a volar flexion here to keep the wrist in a very neutral position. That's why this is kind of angled like this. That's intentional. Let's talk about these distal radius fractures. So that's the number one fracture in all adults, typically from falling on an outstretched hand or a push injury. It can involve the metaphysis or the epiphysis, with or without joint involvement. Diagnosis and management are primarily guided by radiographic evaluation. Some fractures, X-ray is great, and distal radius fractures is a good example of that. There are many different injury patterns. There's the Barton's fracture, which typically involves one of the carpal bones that articulates with the radius. Schurfer fracture, which is a historical name for a type of radial styloid fracture. Colles fracture, which is dorsal displacement of the fracture fragments. That's the most common type. Smith is a volar displacement. It's kind of a reverse Colles fracture. There's also dive punch and radial styloid. And then, of course, if you get in really violent trauma, you get really funky injury patterns, but these are the more common ones. There's also a lot of associated injuries with distal radius fractures. That includes the ulna, as in the case of our patient, scaphoid fracture, distal radial ulnar joint, scapholunate, TFCC. The median nerve is the most common nerve injury, and then lunate and perilunate dislocations as well. The exam generally shows tenderness, swelling, and deformity of the distal radius. On the right, we see a good example of what a typical distal radius fracture looks like. You can see the wrist coming into view here from the right side of the screen. And then you see this big bump on the radius and on the wrist, and you know that there's probably a fracture here. And what you would see on x-rays, you see the radius coming in here, and then you see the distal fragment will be displaced dorsally, which is why you have the bump on the top part of the wrist here. Very classic presentation. X-rays are almost universally sufficient. They look for articular extension, comminution, among other potential findings. CT does give a better bony evaluation, often not needed, but in some cases it's helpful, especially for surgical planning. And MRI is useful for the soft tissue stuff, right? The scapholunate ligament, the TFCC, etc. Here's one sort of example of how you might reduce a distal radius fracture. On the left side of the screen here, you're seeing the finger traps. And essentially what you do is you put the hand in finger traps and you have it at elevation. So this is held above the patient's head, and gravity is helping to reduce the fracture here. And usually, which is not pictured, down at the elbow, you'll have some weights hanging on the patient's arm, so it's under tension. And you may still have to reduce the fracture manually, but gravity can be your friend here to pull this back into some anatomic traction. And then you can see on the right side of the screen, this is an application of a sugar tong splint. So one person is holding the hand up here on the fingertips. They've already applied the web roll, and now they're over here applying the plaster. And they're going to help let that harden, and then they're putting, in this case, it looks like they have an ace wrap wrapped around it as well. You can put some more of the web roll, and then there's usually a stockinette, which you can kind of see right here, which is the first thing that goes on the skin. Management of distal radius fractures really depends on the fracture pattern. If it's extra-articular, it's not really displaced, shortened, or angulated, they do well without surgery. These patients, of course, require close follow-up and serial radiographs, typically in a sugar tong splint for 1 or 2 months. And there's a lot of other factors, right? Patient's age, occupation, is it their dominant arm? What are their other injuries? There's a lot that goes into the operative decision making. Indications for surgery include instability, right? Obviously, if it doesn't stay aligned, it's not going to heal well. If it goes into the joint, there's a greater risk for arthritis, so you really want to reduce those anatomically, surgically. Significant comminution. Our patient had a lot of comminution, displacement, and then other associated fractures that require surgery. You're going to go in and fix the radius anyway. And roughly, depending on where you look in the literature, about a third of distal radius fractures require surgery. As far as complications go, up to 80% from 6%, depends on what literature you look at. The most common things are post-traumatic arthritis and malunion where the distal radius fracture doesn't heal correctly. All right, so in our patient, he went to surgery about a week later where they did dorsal plating with a radial styloid plate. And what you see here is the dorsal plating, okay? And then you see the actual dorsal plate extending down here into the third metacarpal to keep the wrist in a neutral position so it's not bending and allow everything to heal as anatomically as possible. This is kind of an unusual surgical management. The patient did well in follow-up. He still had some swelling at 2 weeks, but that repeat x-ray showed good alignment. At 2 months, he had good bone bridging and the alignment was maintained. And a couple months later, they removed the dorsal plate. And then down here on the bottom, you can see what that looks like. This is with the dorsal plate removed. At the last follow-up, he was still having pain. He had started physical therapy, but unfortunately, he did not follow back up with the surgical team. So 3 key points about distal radius fractures. The first is that they're the most common type of fracture in humans, typically resulting from a fall on an outstretched hand. There are a variety of injury patterns that can be diagnosed radiographically, with the Colles fracture being the most common variant. And management depends on many factors, with the goal of achieving anatomic alignment and then maximizing post-fracture wrist dysfunction or maximizing function with either surgical or non-surgical approaches.